Welcome to the Resilient Training Lab podcast.
Hello, welcome to the Resilient Training Lab podcast. My name is Ryan Kalkowski. With me is my co-host Paul Milano. Today we have a special guest, Eric Lagoy. Eric is a doctor of physical therapy. He completed his undergrad in kinesiology and his DPT from the University of Connecticut. He's a board-certified orthopedic clinical specialist. He treats out of Gaylord Orthopedics in Cheshire, Connecticut. When it comes to the Resilient Training Lab team, Eric's the director of programming, and he's also an adjunct professor at Quinnipiac, where he teaches a class called Exercise Physiology and Prescription for the Physical Therapist. And today we're going to talk all about lower back pain and lifting weights. So welcome, Eric.
Yeah, thanks. Thanks for having me, guys. This will be fun.
So today we're hoping to talk about low back pain and lifting weights. So I was hoping to start with maybe some statistics on lower back pain, how it'll affect us in the weight room and the rehab setting. So with that, I'll pass it over to you, Eric.
All right. So the general statistics on low back pain, there's actually quite a bit of data all over the world on this stuff. So the lifetime prevalence, meaning the likelihood that you're going to have low back pain at some point in your life is pretty high, up to, depending on who you ask, it can be up to 90%. So most people, the vast majority, at some point in their lives are going to have an episode of low back pain. So in that sense, we can almost say that it's normal to have low back pain at some point. Within that, the vast majority tend to get better within a couple weeks to a couple months. So just because you have low back pain doesn't necessarily mean it's going to be something serious. In fact, of the 90% of people that experience low back pain, 99% or more of those are not due to a serious issue like a cancer or tumor or something like that. So those are probably the biggest statistical figures I like to throw out there when I have these sort of conversations with people, because it can be scary to have low back pain and you might feel like you're the only person that has it, but most people have had it, and if they haven't had an episode of low back pain, they, statistically speaking, probably will at some point.
So it's part of everyday life. We're probably going to experience back pain at some point or another, regardless of what activities we're regularly participating in.
Correct. Yep. Yeah, whether you're sedentary or active, or you do weight training or running, or the statistics seem to stand regardless of a variety of other factors, although there are factors that might affect how we recover from an episode of low back pain. And again, I just would stress that the majority of it is probably not a big deal, in the sense that it's not something super life-threatening or serious. So I said less than 1% account for serious issues like cancer. And then there's maybe 5 to 10% that we can identify a structural issue like a fracture. But then the majority of them sort of fall into this. We don't always have a specific structure that we can identify as the source of the pain experience.
So it's really common for somebody to want an answer to maybe why they're experiencing their pain, but what you're saying is that there's not always a concrete answer. You can't look at a picture or an image of somebody's spine or their back and necessarily tell exactly what's happening.
Yes, so if you have low back pain and you go to the doctors, they will probably initially start with an x-ray, which just looks at your bones. And really, what we try to do with that information is rule out the really serious stuff. Because even though it's 1% or less, we still want to occasionally make sure you don't fall into that 1% or less category. So an x-ray can tell us something like if there's a fracture or a stress fracture. It can tell us other information like degenerative changes, but how those associate with pain is a whole different conversation that we'll probably get into a little bit. So yeah, it's not always a big deal, though. I don't know if that really answers the question, but
Absolutely. Paul, you look like you were about to jump in there and say something.
So you keep mentioning there's these kind of 1% of cases that might require a little extra attention. What kind of like red flag signs are you looking for when you are assessing someone that might raise concern?
Yep. So history of cancer and unrelenting pain is one of the red factors that we look at. So if somebody,
Could you describe what might be considered unrelenting pain versus maybe an acute scenario where there's persistent low back pain?
yeah, so typically acute pain will fluctuate with various activities or throughout the day. So when we say unrelenting pain, we're referring to pain that is constant and does not change regardless of what position you're in or what you're doing. It's always there and it doesn't seem to change. So typically with acute low back pain, somebody might say, yeah, I can sit for a little while and then I'll go to stand up and I'll feel stiff or achy, or if I bend forward, that might feel stiff or achy, or if I lean backwards, all these sort of pain experiences that are identified with some sort of movement or physical activity or something. Unrelenting pain is when none of those things seem to make a difference, good or bad. And then history of cancer is just something else we ask from a screening perspective. To get more into specific pathologies, we look for something called Aquinas syndrome, which the symptoms for that include things like saddle paresthesias, so numbness and tingling across the buttocks area, and loss of bowel bladder control. So these are serious issues. It's not just localized to the back, but if someone comes in that says they have low back pain and numbness tingling into their buttocks area, and they report that they're having issues with urinary incontinence or loss of bowel function, then those are what we consider the serious cases, which I fortunately have not seen clinically, but I still have to rule that out when someone comes see me.
And so the process for ruling stuff like that out looks like what?
Well, from my perspective, it's done through a thorough history and subjective exam. So medical doctors can order imaging. So in the case of cancer, an x-ray might not show you something like that. Most of the time, an MRI might show something more like a tumor. But again, if someone comes in and they said that they've had back pain for a couple days and they threw their back out, quote unquote, doing some sort of activity, and they report no symptoms of bowel bladder function loss and their pain seems to fluctuate throughout the day, then I'm probably not looking too much into that 1% case. There are other things that I'll look at from there to try to determine if it's non-specific acute low back pain just to the back, or if there's leg pain associated with it. But that gets outside of that 1% or less that we were talking about before.
Mm-hmm. So if we move on from the 1% and we start looking at the 99% of back pain patients that you might interact with in your clinic, or we might end up seeing lifting weights with us, what does your process look like there?
Yeah, so for acute low back pain, I think a lot of people probably don't come directly to me because most acute low back pain seems to resolve within 4 to 6 weeks, maybe a little bit beyond that. So I think a lot of people kind of wait it out and try to just modify activity on their own and likely do okay. So acute low back pain, I'll see a couple cases a year clinically, but usually when I see people, it's episodes that have been ongoing for several months or longer, which starts to differentiate acute versus more persistent type pain. But moving on from that 1% into the 99%, the majority of those do fall into non-specific low back pain, which really is just a fancy way of saying we can't identify what the specific structure is that seems to be contributing to the pain experience. And it's extremely multifactorial. It doesn't mean that the structural aspects of the back don't matter. It's just that we are unable to identify a singular source of discomfort. So a lot of people will go, as an example, a lot of people go to the doctors and they'll get that x-ray to rule out a fracture. And then when they do the x-ray to rule out the fracture, they'll notice that there are some degenerative changes consistent with arthritis at a certain level, like L4, L5. And then the doctor or the patient might make the conclusion that the degenerative changes are causing the discomfort that they've been feeling for the last couple weeks or something. And it's a little bit more complicated than just seek and destroy, looking for a singular source of pain, and that's kind of causing the whole issue. So it gets kind of muddy in some aspects, but that's part of the job.
Maybe a little oversimplified from the clinician's perspective?
Yes, yeah.
Or the doctor's perspective?
Yeah, well, I think, one of the things that we know patients want when they see a healthcare provider is they want validation that they're experiencing pain, and they want some sort of diagnosis and prognosis associated with that. So I think as a healthcare provider, if someone comes to you and they say, my back hurts, they want to recognize that you're hearing that and validate them. And then ideally, you'd be able to tell them, well, this is why your back hurts and this is what you do to get it better. And we, statistically speaking, are not very good at doing that. So when I see someone with low back pain, I like to save some of that conversation until after the exam. And then I might lead with, well, we've ruled out these red flags, these serious issues. And while I understand that this is serious to you and that you're experiencing pain, we can kind of treat it according to this model. And I think it'll get you where you want to be. And then sometimes I do try to label it in some capacity, which might just be something as simple as saying, I think this is more muscular of origin, or something like that. Just because we know that patients do want the validation and diagnosis given to them.
When you were talking about validating the feelings of your patients and this person experiencing back pain, I think you had mentioned that statistically we don't do so good of a job at making them feel heard and that their feelings are real. Could you touch on it a little bit more, go a little more in depth on that?
Yeah. So I think if you go, I use the seek and destroy analysis. So if you go to a doctor with some sort of issue and they will take the approach that they're trying to seek out what is generating that issue or that source of pain and then how to fix it. So it's this sort of seek and destroy approach to managing symptoms, but that's a very biomedically driven approach to healthcare. It's a very input-output driven approach where if I do this, this will fix this problem and therefore your pain will resolve. And while that may validate the pain experience, the fact that there is pain occurring to a patient, it's not exactly enough of maybe a holistic approach to determine how this pain experience is affecting this person, this individual. So somebody that has acute low back pain that functions pretty well during their life, but is just unable to deadlift or squat at the gym, some people might kind of shrug that off as not too big of a deal, but to that person, if that's their main social outlet and they really enjoy doing that activity, that can be a big loss to them. And they might worry about when they're going to get back to doing some of those activities and being with their friends and their coaches and possibly competing again or whatever that might look like. Whereas if somebody else, can't do those things and they don't really ever do those things or want to anyways, it's a completely different experience. So when we talk about validating pain in the literature, what we're talking about primarily is this patient feel like they're being heard? And I think that just gets a little bit more complicated than just simply identifying some sort of structural issue that's causing their symptoms, but actually taking more of a person-centered approach to how we treat that individual.
Right. If somebody's super involved in the powerlifting meets and prep, if they can't do their lifts, that's going to be a really big alteration to their training. So if somebody is experiencing an acute bout of lower back pain, is lifting going to be something that they're going to want to completely avoid until that back pain resides?
So if there's somebody the short answer would be probably not. If there's somebody that has experience lifting and they enjoy lifting, I'm probably going to incorporate some form of lifting into their rehab program. It's likely going to be regressed from what they might normally want to do, but there's a lot of ways we can regress that. So we can modify the intensity, the range of motion, the frequency, whatever variable we want to manipulate. But yes, I will definitely include some form of lifting for a lifter with low back pain. On the other end of the spectrum, if I have somebody with low back pain that has zero experience lifting and they are fearful of lifting because they think it's going to make their back worse, I have to ease into that a little bit differently because there's no prior experience with lifting there. There's fear associated with the movement of lifting. So the goal might be to get them to be able to do some level of lifting so they feel strong and promote self-efficacy and locus of control and these things that we know are important for outcomes in this population. But it's not going to be as simple as modifying the load or changing the range of motion for that individual because there's just a little bit more going on.
So you mentioned that you often see this seek and destroy type of logic kind of given to low back pain. And then you had mentioned that you often see patients that come in and they're fearful of some movements. Do you think that sometimes these things are correlated? And do you think, could you expand on maybe some of the other downfalls of strictly looking at a person from their imaging results and from a biomedical standpoint?
Yeah. So to the first part of your question, yes, it is certainly, that gets into the idea of a nocebo, right? So can we provide somebody with some sort of information that might result in a negative outcome, essentially? And this is something we see a lot in a lot of areas, but particularly in healthcare. So some other quick statistics: people get information about how to treat or manage low back pain from a variety of sources: friends, families, media, and then also healthcare providers. And healthcare providers are consistently put at the top of the kind of how they funnel that information that they're receiving, which makes sense because that's our job. So if a healthcare provider tells somebody one thing and then a family member tells them one thing, they're going to give a little bit more weight to what that healthcare provider says. So healthcare providers do have an obligation to make sure that we're providing correct information, and that we're, using the epidemiological data that I was just talking about, meaning low back pain is very common. Acute cases tend to, the vast majority tend to be nothing serious, and they tend to improve, have a good prognosis within a few weeks to several months. So that information alone, I think, doesn't even reach the individual seeking care. They just get right into the seek and destroy approach to managing that, which leads down this funnel of, overdiagnosing and nocebo and instilling additional fear into somebody that's already sort of scared. Because I can tell you, I work with all different injuries and everything, and people tend to get the most freaked out or scared when it comes to their back. Somebody's knee or shoulders bugging them a little bit, it's not fun. It's a painful experience, but I don't see the same amount of fear consistently that I do when someone hurts their back. So I think that being careful with how we speak to patients is key. And I think understanding some of the statistics that we're talking about right now is key to being able to educate people on what exactly is going on, or maybe if we don't know exactly what's going on, what we think, the prognosis and diagnosis might look like.
When you have a patient coming to you who's experiencing low back pain versus, say, some shoulder pain or elbow pain, do you notice if one of those populations is maybe a little bit more hesitant to lift weights or to move, and they believe that rest is the best thing for them, versus maybe somebody with their shoulder, they're a little bit more open to exercise as a treatment?
Yeah, so one of the things that we'll ask, if someone comes in to see me, we'll sit down and I'll ask them, what are you here for? What can I help you with? And I'll let them kind of give their whole speech to me on what's going on, what led them to come into therapy. And then we start kind of doing this little back and forth conversation. One of the questions I'll ask the patient is, what do you think's going on? And what do you think might be helpful? Or what have you tried so far to help manage this? And that gives me a lot of information. So if they're saying, well, I think, my back's out of alignment and I've been trying to avoid any lifting and just kind of taking it easy and putting some heat on it, and, I really think that that's what I need, and maybe some sort of massage or something might help as well, then that's going to be a different conversation from there out than the person that says to me, well, I think I need to get stronger so that this doesn't happen again to my back, which might lead to other types of conversations. So I try not to put words into my patient's mouth or just start over educating them. I like to ask them what they think is going on and then take that information and reframe it sometimes. But these are also, most of the time, people that I've just met. So I don't want to come in as the new guy that's kind of, talking shit about all the other information they heard from their doctors or their friends, their family members, or that might conflict with what their beliefs are coming in to see me. So asking somebody what they think might be going on, what have they done to help manage symptoms, what do they think the expectations are, what would they like to see in therapy happen, tells me a lot of information on the approach I'm going to take moving forward.
So I think that's something that we kind of see bleed into the weight room a lot too, is that fear of, hurting their back, and how that seems to be a more prevalent fear than pretty much anything. It's almost something that comes up in like 75% of the assessments we do. It's a topic that constantly comes up, and there's this kind of idea out there that our spines are fragile and that they're going to break easily. And that message is not only incorrect, but is actually kind of harmful. Do you have any more information on that?
Yeah, I find that just your anecdotal information interesting, because you would think, if you're listening to this, that the people that might be fearful of moving or exercising are going to be people that are more sedentary or frail, and people that are bigger and stronger might not have those fears necessarily. But I don't necessarily find that to be the case, because these fears and these beliefs regarding how to manage something like low back pain, it's a little bit more complicated than just what their prior history has been with activity. And that goes back to the other stuff we were talking about, where do people get information about how to manage their symptoms? And they primarily get them from healthcare providers. So if we're out there telling people that their spine is fragile and that they're out of alignment and that they can't do this until they're able to do this, and all these sort of things that are limiting people, then we could be creating more harm than good, is how I'll say it. And I think when doctors and healthcare providers and physical therapists and chiropractors make these claims to people, they're not bad people. They're well-intentioned, but I think it's kind of just aired so far on the conservative side, where instead of telling somebody it's okay to move within your tolerance and, giving them some general advice, it's gotten to this point where we just err so conservatively that we try to avoid pain at all costs, and we end up over-limiting people and instilling more fear, and then that leads to greater amounts of disability and lower levels of self-efficacy. So I do see that as a big problem. Yeah.
So it sounds like you're saying we almost end up creating more problems when we look for living life pain-free and never having to encounter any sort of discomfort when it comes to certain areas of our body and our daily activities.
Yeah, you're not going to live your life pain-free, whether it's back pain or not. In fact, people that can't experience pain tend to not live very long. It's a very challenging life for those individuals. It's a very rare disease, I believe. But pain is there for a reason. It's something that's supposed to help us survive. So trying to avoid pain completely will be a frustrating experience. And even knowing when to differentiate aches and pains that might be normal from more serious issues of pain can be challenging. So it is a complicated thing.
Yeah, no kidding. So if somebody is experiencing a sensation of pain, how do you differentiate whether or not you're just trying to manage the symptoms of it, or if we're looking at trying to reduce something that might be contributing a little bit more to the pain versus like a symptom, and how those two are different from one another?
So labeling pain as a sensation is kind of a gray area. Okay. Because really, sometimes I think when we say pain, we assume we're talking about something called nociception, which is fibers that can be stimulated and send a signal up to our brain. And then nociception fibers are often associated with pain. And therefore, people will say that they're having a sensation of pain, but pain as a definition is a little bit broader than that. And we consider it more of a sensory and emotional experience. So just that sort of a buzzword when you say pain and sensations and all these sort of terminologies in my world anyways. What was the other part of that question?
If we just look at dealing with symptoms versus pain and trying to prevent symptoms and pain.
Yes. So I always like this particular topic because something that might help manage pain does not necessarily mean that it's going to prevent symptoms from ever occurring. And I feel like that's a huge area that gets confused in the media and with healthcare providers. An easy example of that would be something like foot inserts, right? So if you look at the research on foot inserts in terms of preventing pain. So if you put like Dr. Scholl's or even custom orthotics in your shoes, will that help prevent the onset of low back pain? The research does not look, on average, particularly promising for that. So if somebody comes in and says, I'm scared I'm going to have back pain again, should I go out and spend $400 on orthotics to help prevent that? Probably going to say, I don't think that's something worthwhile. On the flip side, though, if somebody is experiencing low back pain at the moment, and they are somebody that's on their feet all day, and being on their feet seems to exacerbate their symptoms, and they ask me, would putting in a pair of over-the-counter, shoe inserts possibly help with my symptoms, my pain? Maybe. We don't really know either way, but an over-the-counter $20 pair of Dr. Scholl's is a low-cost intervention option that might be helpful. So that's just one example to sort of illustrate preventing symptoms. So would orthotics prevent low back pain? Probably not. Versus trying to manage symptoms. Could this help me feel a little bit better over the next few weeks? Possibly. So that applies to pretty much everything. You can take this with stuff at the gym like foam rolling, right? Will foam rolling prevent low back pain? Probably not. If you are having low back pain, we'll roll around the foam roller for a few minutes, maybe make you feel better, maybe a little bit. I don't know. I don't know if it's what I typically recommend, but this comes up so much in a clinical setting where people think that if something helped them feel better in the moment, then it must be good and therefore will prevent something from happening in the future. And we just don't really know that a lot of times. Not a lot of things really seem to help prevent low back pain. I mean, that's why the vast majority of us experience it at some point, so.
And then taking that even a step further, things that you might program for someone while they're experiencing low back pain, would you want to see that person continue to do those things even once they're not in pain?
Yeah, it depends. My programming style for someone with low back pain continues to evolve and hopefully will continue to evolve for as long as I'm doing this stuff. But for an acute bout of low back pain, it's really gotten pretty simple for me. And it's taking a look at what they would normally be doing and then taking a look at what they're currently doing and seeing if there's a little bit more wiggle room to do something sort of in the middle. So an example I'm thinking of right now, I have a patient that previously would wake up and ride his spin bike for an hour every morning, and that was what he liked to do for exercise. And since he has had this low back pain for the last 2 weeks, he hadn't been doing that at all. So we talked about trying to get him to do some level of that, even if it's only 15 or 20 minutes worth of riding the spin bike. So maybe not his previous amount, but something within that realm. And then from there, I might give him a couple feel-good exercises because he's typically stiffest in the morning, and that's when he's most uncomfortable. So I gave him some exercises to do in the morning that seemed to give him some level of relief. So if hopefully a couple weeks from now his pain is gone in terms of at least this bout of low back pain, will I advise him to continue to do the exercises in the morning that seem to help manage his symptoms? Not necessarily, because again, I don't think that is going to prevent a future bout of low back pain. But if he's doing well with the spin and that's what he likes to do, then by all means he can continue to do that. So it's a little bit of both, I guess. If I'm having somebody do something specifically that they don't normally do because it seems to have a positive impact on their symptoms, when their symptoms resolve, I don't necessarily think they need to continue to do that. But a lot of managing low back pain is trying to get people back into activities that they want to do. And then hopefully as their symptoms resolve, they are doing that more and more.
So it sounds like you're kind of just modifying what they're currently doing to a tolerable level, more so than you would say that you're giving people special exercises that will, quote unquote, fix their lower back pain.
Correct. Yeah. Because it goes both ways, right? If most healthcare providers on average seem to be too conservative in telling patients to rest and, avoid lifting or doing X, Y, and Z until they feel all better, that's probably too conservative. But at the same time, we don't want to ignore symptoms and prolong things longer than we have to. So we might have to end up somewhere in the middle and kind of balancing this, not really babying your back just because you're fearful or think it's fragile, but also not ignoring your pain experience and if you're doing something that seems to be consistently increasing symptoms, then we probably do have to find some lower threshold for that. But I really try to avoid completely removing activities that people enjoy if I don't have to. But yeah, there's not a lot of good data for specific exercises, which is another kind of misconception. So there's all sorts of research out there comparing, different types of exercise interventions for low back pain. And on average, they all work a little bit, basically. So, core stabilization versus yoga versus something else. They all kind of work. So why not do what the person seems to enjoy the most is a good place to start.
So I know when Paul and I work with people in the weight room, and they come in for their first initial assessment or their first time in, a lot of them can be nervous. They can be apprehensive on what we're going to do. And so we really try and set the expectation from the moment they walk in the door of, this is what we want to talk about. We're going to take a look at how you do some of these exercises. And we just try and put them at ease right away as soon as they walk through the doors of the gym. So is there some way that you handle interacting with your patients and setting expectations or managing expectations? Because from what it sounds like, there's a lot of gray area in what might work, what might not, how long it'll take for maybe their symptoms to improve.
Yeah, so on my end, again, I like to ask those questions. What are your expectations with physical therapy? Because I get everything and the answer to that. Some people just think they're going to get a foot massage, and some people think they're going to, work out really, really hard in physical therapy and everything in the middle. So what are your expectations for physical therapy? And then what are your expectations for your prognosis? Do you think this is something that's going to get better relatively quickly, something you're going to be dealing with for a long period of time? And those two help frame what my expectations back to them are going to be. So if they come in and they're very anti-movement or exercise in general, and they're primarily seeking passive care, so heat, massage, stim, dry needling, spinal manipulation therapy, then I might have to ease into, not that I'd want to dismiss those things, because I know that you think that they could be helpful, but are you aware that moving can be good for your body as well? And is there any particular part of moving or exercising you enjoy? Like, do you like going for walks, or do you ever think about, going to the gym and doing a little workout in there? Or do you like cardio? And just kind of brainstorming with that individual what that might look like. Whereas if I have somebody that's already active at a gym and enjoys working out, I have a pretty good idea what they want to do. And a lot of people that come see me specifically, they're requesting to see me. That's a lot different than someone that isn't requesting to see me, because when the person in front of me said, I came to you because I know you work with runners or powerlifters or whatever it is, there's already a certain level of validation there, and the expectation that I'm the expert and I must know what I'm talking about because so-and-so recommended to go see Eric. So I can get into stuff a little bit quicker with that individual than someone who just, their doctor gave them a script for physical therapy and they called the office and I had the first available time slot, So there needs to be a little bit more rapport there. And that gets into a concept in therapy that we call therapeutic alliance, which I think would apply to you guys just as well. But therapeutic alliance is basically when a therapist and a patient agree on the goals. What are the goals to achieve with this process? And they agree on the intervention. So how are we going to get there? And there's some level of an effective bond between the two of them. So questions like, does this patient even like me? Right. And checking off those three boxes, so having better therapeutic alliance, does seem to be related with better outcomes, separate from everything else that goes on. So rather than focusing on what exactly I'm going to do with what's, secret exercise I'm going to give somebody, I try to make sure that, does this person even like me? Are we agreeing on, what the goals are and the timelines for how to get those goals? And are we somewhat on the same wavelength for what we want to do to do that, So those are the things that I look at on day one.
From our perspective, we're always in a gym dealing with relatively active people who, for the most part, want to be there. So my question would be, if you're working in a physical therapy clinic, do you have a lot of headbutting when it comes to trying to engage in physical activity or making it a part of their daily life? Do you see a different population than likely the one that Paul and I deal with on most days.
Yeah, I see a pretty wide array of patients on a daily basis, and part of that is because of my specialty. As a strength coach and a power lifter and a sports medicine minded physical therapist, I get a lot of people in that realm and youth sports and things like that. And then the community of Cheshire, it's a wealthier community. It's a well-educated community. So I see a lot of people locally. And then being hospital-based, we accept all insurances where I work. So I also see people from lower socioeconomic statuses. So people on Medicare and then also people on Medicaid. And then being Gaylord Hospital, which is a long-term acute care hospital as a primary base, I see traumatic injuries and complicated cases like individuals with kidney failure or are on chemotherapy or things like that. So I have pretty much every walk of life that comes through the door on a daily basis. And with them comes all sorts of different beliefs and expectations and what physical therapy should look like. Sometimes just reframing exercise into more of an activity is a useful way to do that, though. So if I have somebody from the community that's a grandmother and they're having trouble picking their kid up their grandkid up out of the crib when they're babysitting or something, we might do quote unquote deadlifts or squats or something of that manner. But rather than calling them, I'm just saying, well, let's practice, doing that lifting activity, because that's going to help you be able to pick up your grandkid a little bit better if we get good at that. So something like that. So not necessarily even calling it exercise or the typical terminologies that you guys might be familiar with.
So you talked about managing expectations kind of from like a what to expect from therapy standpoint, but on the sides of like symptoms and what to expect in terms of recovery time and how your symptoms might fluctuate from day to day, what does that kind of conversation look like?
Yeah, so sometimes with that sort of stuff, I like to stay ahead of the game. So there's different types of low back pain specifically, because that's what we're kind of focusing on here. So there's the type that just gets gradually better over time, and then there's a type where it tends to have a lot more ebbs and flows. So there will be flare-ups, things of that nature, and then there's individuals that have more persistent pain. But regardless of those, I like to tell people that it's not a linear process. You don't just get a little bit better each day. There are ebbs and flows, so good days and bad days, but the overall trend should be heading in the right direction as we start a rehab process, I guess. And the reason why I say that is people will come in on day one with me and they're pretty down in the dumps, obviously. They don't want to be there. They don't want to have to come to therapy. They might start working together, and within a few weeks, they're noticing some significant improvements. And then they might have a couple of days or a bad weekend or whatever happens, and they feel like they're back to square one. So rather than look at how someone's symptoms are on a daily basis, I like to look at how things are going on a week-to-week basis, or in more persistent cases, so cases that have been going on for months to years, we might look at progress on a month-to-month basis. And if, just because Tuesday was a bad day, if, March was a better month than February was, we're still heading in the right direction, right? So it just kind of keeps a big picture, a bird's eye view of what the rehab recovery process is looking like, and try not to, let a bad day slide too far back. And I like to have that conversation before that first sort of bad day happens, right? Because then that hopefully will, alert a little reminder, a little voice in my voice inside their head saying, Eric said this might kind of happen. And then obviously we talk it out when they come into therapy. So we'll look for any sort of precipitating factors. So for something like low back pain, a flare-up, one of the most predictive causes for a flare-up is actually prolonged sitting. So sitting for more than 6 hours is more likely to cause a flare-up of low back pain than just being generally active. So if I have an individual that, and this happens every now and then, they had an acute bout of low back pain, took a couple of days off of work, started coming to therapy, went back to work halfway through the week, got to the weekend, was moving around, and they go back to work the next week, things are heading in the right direction. And then if they have a desk job, all of a sudden they're back to sitting for 6, 7, 8, 9 hours at a time. And then that might be something that's more likely to flare them up than anything else.
As someone who has experienced low back pain, it's very easy to get kind of caught up in how you feel on that particular day and to kind of start to put yourself in a negative downward spiral where you start to have a bad day and start to talk negatively and start to kind of slip into some of those things we were talking about earlier about being fearful and having this image of having a fragile spine. So I think it's very important that you are able to step back and kind of see the big picture.
Yeah, it's easy to say these things, and I've had the occasional achy back too. So, and I mean, I'm highly trained and specialized in this area, and it's still hard to manage, even myself. When I have that 1 week bout of low back pain, that doesn't even really affect my life that much. So, going through that experience, I can appreciate how challenging it can be, and how scary it can be for people out there that are dealing with this stuff. So I kind of get that aspect of it as well.
So I know the three of us have talked because maybe about a month ago I was dealing with that myself, and I'm talking to clients about this all day, and it happens to me, and I have to look at what I'm doing, and I immediately just had to talk myself off the ledge and be like, you know what, this is okay, like I'm gonna be fine. And it is very difficult to do that, even with all of the information at your fingertips. And so, Eric, in your opinion, at what point is pain something where the person should involve a physical therapist or a professional? When is it too much and they should seek out?
Yeah, that's a good question. Certainly, if you have any of the red flag symptoms or signs that we were talking about before, so loss of bowel, bladder control, saddle paresthesias, things of that nature, unrelenting pain, you might want to seek a healthcare provider. If you're just talking about general aches and pains for this podcast, something associated with training, I would look more at your programming first before I would seek out a healthcare provider, because they're not going to most likely understand the intricacies of program design and how that might affect how you're feeling on that aspect. If your pain is really affecting your sleep or it's really affecting your quality of life, so not just with the gym stuff, but you're not doing social things that you would normally be doing. And again, if your sleep's affected, it's going to start to transcend into how you feel and other aspects as well. That might be an indication to seek care as well. So I always go back and forth on this, because I would not want to make it downplay something where somebody should have went to a healthcare provider, but at the same time, a lot of times when people do go to healthcare providers, they probably don't have to. So, if you have a good relationship with a physical therapist or a doctor or a chiropractor, whoever it is, and you just want that validation that nothing's wrong and that you're not doing anything that you shouldn't be doing, then that might be okay too. So I think it's a little bit different for everybody. I think it depends on your relationship with the healthcare provider you might go see. So, if you guys have somebody that's been complaining about low back pain for a while, and it starts to feel outside of your scope, so you say, well, why don't you, call Eric up and talk about it? And, that person might only need to come in for 1 or 2 visits, and then we just talk for a little bit about the prognosis and what's going on, rule out the red flags, maybe make some subtle modifications to their training program, and then that could be all it is. So it doesn't always have to go down this rabbit hole. But for a lot of people, you take something that's probably not a serious deal, and then you go to the doctors and they do the x-ray, and then they found something else was going on, and they tell you to stop doing something you enjoy, and then you start to get into the nocebo language with, don't do that or else, or you're going to pay the price in 20 years for doing that, and it just becomes a whole shit show real quick, So I don't know. It's a hard thing to answer, because my approach is a little bit more pragmatic. So I feel like if you had a problem, let's just talk about it. And hopefully it's only something that needs 1 or 2 visits. It's not something that should be really time consuming, but I realize for a lot of people, it doesn't work like that, So it's more of a problem with our healthcare system, I guess.
Do you have any recommendations for somebody out there who might be experiencing pain that isn't involved with maybe a a group of people such as the three of us who doesn't have a strength coach helping them or the resources to find somebody, maybe a qualified healthcare provider?
Yeah, there are a lot more resources now. There's a Clinical Athlete, which I'm a part of, which is basically a network of healthcare providers that walk the walk. So most clinical athlete clinicians compete in some sort of activity or at one point did, and we tend to, I think on average, tend to be a little bit more up on current trends in healthcare and research. There's other resources like Barbell Medicine, which has a team of doctors and chiropractors and physical therapists that definitely are in line with a lot of the content that I'm talking about right now. And, hopefully this is something we can put up, for blogs and stuff like that. So there's content out there for sure if you do a little bit of digging first. And with the world getting more and more connected, I think it's a good thing for healthcare because telehealth's going to probably be a much bigger thing in, the foreseeable future. So if you are some sort of powerlifter or whatever, runner or something like that, and you want to work with a clinician that is, up to date on research and also understands what you're trying to get back to doing, even if they don't live local to you, you could probably still connect with them. And I have people do that a decent amount, even just through like Instagram, just message me and ask me a quick question or ask if they could shoot me an email, or they might live semi-local. That happens a lot where someone lives in Connecticut, but they live down in Niantic and it's an hour away or something to Cheshire. So they're like not really sure if they should come in or not. So I might have them come in for a one-time visit and then figure out what we want to do from there. Cause I understand that they can't come into the clinic, consistently, but sometimes these things don't need consistent visits if they're motivated and we have a good game plan in place and we communicate via email or something.
So if listeners are looking to get in contact with you or find more about some of these topics that you might have talked about, where can they find you? Yeah,
I'm probably on social media. I'm probably most active on Instagram. So it's just Eric_resilient. My email is lagoy@gaylord.org. That's my clinic one, at least. So if it's a clinical question, you can email me there or DM me on Instagram. I'm not really on Twitter or anything really, or Facebook too much, but I'm in Cheshire. So if you're anywhere within that distance and you think there's something I could help you with, then you can message me and we can figure out how to set something up.
And do you have any contact or content out on Clinical Athlete or any blog posts or other podcasts you're on?
I was on a podcast for Clinical Athlete. I don't know what the episode number is, but if you just scroll through it and look for Eric Lagoy, I'm on there, and I'm on another podcast for something called Missing Variable. Both of those are about the course that I teach primarily for Quinnipiac University, because hopefully the course that I teach will be more common in other DPT programs in the future, but they wanted to pick my brain about how I got that rolling and what the course looks like. So that's mostly what I do. And then for Clinical Athlete, I have a webinar, but it's not really pain focused. It's on hypertrophy training in a clinical setting. So that's on the Clinical Athlete forums. And then in the summertime, in September, actually, I'll be doing a presentation for Clinical Athlete and Level Up Initiative, which are more healthcare driven. But if you're a healthcare provider listening to this of any type and you want to meet up with me in person and listen to a bunch of other smart people, smarter than I am, talk about various topics in September up near Boston, we'll be doing that. So that'll be fun.
Talking about low back pain there, right?
Yeah. Yes, I am. I got the biggest topic of all the options. So I drew the short stick on that one.
Paul, anything else you want to get in?
Yeah, if you want to just kind of give a quick summary, I think we touched on a bunch of kind of things that are popular that may or may not work, and some things that are often overlooked that do have an impact on the rehab process. If you could just give like a quick overview of that before as our closing statement.
Okay. Yeah. So if we're to look at what's most effective for helping low back pain, I would say time is a big one. And that gets into something called regression to the mean. So things tend to improve over time on average. Being somewhat active, so not being too sedentary or sitting for too long, also seems to be a good component of that. What that looks like, we don't really have a specific protocol that we follow for low back pain that seems to be more effective than anything else. So there's, some people that might do core stabilization like McGill's Big Three, so bird dogs and side planks, and those could be good options for some people, but they don't necessarily outperform any other option like Pilates or weight training, or even some level of aerobic activity seems to have a positive benefit. So those are the areas that I would focus on. And then a lot of it's just the typical stuff that doesn't get talked about enough because it's not super sexy, but not smoking a pack a day or drinking a bottle of tequila every night, getting quality sleep, managing your stress in other areas seems to have a good impact on the recovery process from any injury, and that includes low back pain. The stuff that doesn't seem to work as well is a lot of passive modalities, so heat, electrical stimulation, dry needling. Those things may provide some level of short-term relief, whether that short-term relief is going to be a few minutes or hours after that treatment was provided or not. I don't think we always know, but I think where a lot of people fall into that is if they start receiving a treatment that's more passive, like manipulations or adjustments or massages, and they do that for 3 to 4 weeks and feel better, they might attribute the improvements to that intervention when in fact they might have just gotten better because it was time to get better. So always just kind of be skeptical with what you're doing, but at the same time, try to stay positive. That's probably the biggest advice I can give.
Yeah, that was perfect. Great way to end. I think this is a huge topic that, we could talk on and on about for multiple episodes, and we'll be sure to have Eric back on to kind of dive into some of these topics a little further.
For sure.
So what about Resilient Training Lab? Where can people find more about RTL and who we are and what we do?
So we're the Resilient Training Lab, your team here. You can find us on Instagram and Facebook at Resilient Training Lab. You can look us up at www.resilienttraininglab.com. We have a blog and a podcast, and we post regularly on social media. And you can make sure to follow our coaches that are here with you today. We have Ryan at Ryan_resilient, Eric, as he said, at Eric_resilient. And then you can find me at Paul_resilient. Try to keep it nice and simple for you.
I'm sensing a theme here.
Yeah.
All right. Well, Eric, thanks a lot for your time, man. You got a lot going on. Paul, you too.
Yeah, it was fun. I definitely want to be back on again.
I'll have to find another topic for you.
Yeah.
And of course, plenty of topics.
All right, cool. Thanks for having me, guys.
All right. Thank you for joining us for the Resilient Training Lab podcast. Till next time.